Have you ever felt like your brain is just this chaotic radio station?
Oh, yeah. That is a great way to put it.
Right. Like, picture this for a second. You're sitting in your car, you're trying to listen to the news, but the radio is simultaneously
Mm.
playing 3 different stations at maximum volume.
Just absolute noise.
Yeah, exactly. And to make matters worse, there's someone sitting right next to you in the passenger seat, just rapidly twisting the tuning dial back and forth.
Oh, man, that sounds exhausting.
It is. You're catching like a fragment of a pop song and then a sudden weather report and then just a huge blast of heavy static. And you are just sitting there, completely exhausting yourself, trying to decipher the one single broadcast you actually need to hear.
And, that imagery captures an invisible, often deeply misunderstood neurological reality for millions of people. I mean, it perfectly frames the fundamental mechanics we are taking apart today.
Exactly. Because today's mission for this deep dive is to completely move past those outdated, honestly, just tired stereotypes of ADHD.
Right, the attention deficit hyperactivity disorder stereotypes.
Yeah, we are throwing out that old cliche of, little boys who just can't sit still in a classroom.
Which is such a narrow view.
It really is. So instead, we are diving deep into some highly detailed medical and pharmacological dossiers. Our goal today is to deconstruct the actual neurobiology of ADHD and explore how it drastically changes shape across age and gender.
And really demystify the exact literal science of how these treatments physically alter the brain.
Right. So looking at the sources, where do we even begin?
Well, when you look at the modern clinical guidelines, the most profound shift is realizing that the pathology of ADHD is not it's not a character flaw.
It's not just someone being lazy.
Exactly. It is not a behavioral choice. It's actually a highly specific hardware issue.
A hardware issue. Okay, I like that.
Yeah, but before we can even begin to understand the outward behaviors you see in, say, a classroom or a boardroom, we have to look under the hood at the brain's internal wiring.
Right, the actual biology of it.
Right. Specifically, the dysfunction happening within the frontostriatal and frontocerebellar circuits.
Wait, let's pause right there and translate that for anyone who doesn't have a neurology degree, including me.
Oh, sure. Yeah.
Frontostriatal and frontocerebellar circuits. What are those parts of the brain actually doing for us?
Fair question. So think of the frontostriatal pathway as your brain's reward and motivation center.
Okay.
It dictates how you evaluate a task and say, yes, this is worth doing.
Like getting up to do the dishes or something.
Exactly. The frontocerebellar circuit, on the other hand, deals heavily with timing, motor control, and predicting what happens next.
Oh, I see.
So when those circuits aren't communicating properly, the whole system of executive function,
Like planning and focusing.
right, planning, focusing, acting, it all just starts to break down. And the culprits behind that breakdown are 2 crucial neurotransmitters, dopamine and noradrenaline.
Okay, this is where that radio tuning analogy really clicked for me when we were reviewing the sources.
Yeah, it fits perfectly.
Right. Because in the brain's communication network, dopamine is basically the signal of interest. It's the chemical that highlights what you actually want or need to focus on.
It runs your executive functions.
Exactly. And noradrenaline, meanwhile, is your filter. It's the mechanism that blocks out the useless background static.
And the medical texts actually map out the math of this disorder based on those 2 chemicals. It's all about the ratio of noise to signal.
The noise-to-signal ratio. Oh,
Yeah. If a person has a decrease in dopamine, the result is high noise. Their thoughts become highly volatile, bouncing rapidly from one idea to the next.
which outwardly, I guess, looks like extreme distractibility.
Exactly.
Because the main broadcast, the signal of interest, just isn't strong enough to hold their attention over all that static.
That's the core of it. And simultaneously, when there is a decrease in noradrenaline, the overall signal becomes weak.
Oh, wow. So you get hit on both sides.
Right. The brain basically loses its capacity to maintain a thought or hold concentration over an extended period. The filter is broken.
So the biological goal of treatment is to synchronize those 2 circuits. Give the brain a clear signal while effectively filtering out the distractions.
Precisely.
Let's bring this back to you, the listener, for a second. Think about a time you tried to get some focused work done in a crowded, really noisy cafe.
Oh, that can be tough even on a good day.
Right. But for a neurotypical brain, noradrenaline is acting like a pair of high-end noise-canceling headphones. It naturally dampens the chatter of the baristas, the clinking of coffee cups, the music playing overhead.
It pushes it all into the background.
Yeah. But for an ADHD brain, lacking that proper noradrenaline filter, The cafe noise is absolutely deafening. Every drop spoon is like an alarm bell.
And because their dopamine is also low, the signal of the spreadsheet or the book right in front of them is just completely lost in that overwhelming sensory static.
It sounds like an exhausting way to navigate the world.
It truly is.
Which really makes me wonder, I mean, if this is a fundamental hardware issue, like a literally broken radio dial happening at the neurobiological level, how did the medical community spend decades convinced this was just, a phase that hyperactive 8-year-old boys go through?
Well, the statistics certainly tell a deceptive story if you don't look closely.
What do you mean?
So ADHD affects about 6 to 9% of children. But historically, the screening ratio has heavily skewed male, with 3 boys diagnosed for every 1 girl.
3 to 1. That's a huge difference.
It is, and the reason for that discrepancy comes down to how society observes disruption. Boys tend to exhibit more of the classic outward hyperactivity and impulsivity.
Like climbing the furniture or interrupting the teacher.
Exactly. That immediately alerts parents and educators that something is wrong.
It's visible.
Highly visible. But as these populations age into adulthood, the diagnostic ratio equalizes to 1 to 1, men and women.
Wait, 1 to 1. Which means those girls always had it, they were just completely missed by the screening criteria.
They were completely missed because the symptoms evolved drastically over a lifespan.
Oh, so?
Well, in young children, you see the constant physical movement, the difficulty starting tasks, the lack of a social filter. But about 50% of those cases persist into adulthood, and the disorder morphs.
So where does all that physical bouncing off the walls go? Because adults with ADHD aren't usually like running laps around their office.
Right, they aren't. That physical hyperactivity often goes internal. It turns into an intense, unyielding mental restlessness.
Like a brain that simply will not turn off.
Exactly. Or it channels itself into lifestyle extremes. Adults with ADHD often gravitate toward excessive physical sports, highly physical careers, or thrill-seeking behaviors.
Oh, that makes total sense. And the impulsivity changes too, right?
It does. It's no longer just cutting in line at the playground slide.
Right. In adults, the sources say that same lack of an internal brake pedal manifests as a road rage, sudden impulse buys that just drain a bank account, or explosive interpersonal conflicts.
Yeah, they struggle to modulate ideas and maintain long-term motivation. But the way this presents in women and girls is where the diagnostic bias really becomes glaring.
Let's talk about that, because females generally present with significantly less outward hyperactivity, right?
Yes. However, they experience the exact same levels of internal impulsivity and distractibility. What happens is that women and girls struggle deeply to modulate their emotions and ideas, but they internalize all that chaos.
And the sources point out that this internalizing often gets mislabeled as anxiety or depression,
All the time.
which leads to years of ineffective treatments and misdiagnoses.
It's a huge problem in the field.
There was a detail in the research regarding this emotional presentation that I found genuinely heartbreaking.
Which part?
Well, because these individuals are constantly failing to meet neurotypical expectations, forgetting appointments, losing items, missing deadlines. Imposter syndrome and intense feelings of incompetence become their baseline. The dossier explicitly states that for individuals with ADHD, success and achievement are the only antidotes to low self-esteem.
It is a profound clinical observation. I mean, their self-perception is fundamentally altered by the repeated friction of living in a world not built for their neurology.
Yeah.
And it is vital to emphasize that this friction isn't caused by, bad parenting or a lack of discipline. The heredity factor is massive.
The genetics.
Yeah, there is a 75% genetic variance, which jumps to 80% if we are looking at identical twins.
Wow.
If one parent has ADHD, there's a 50% chance their child will inherit it.
And beyond genetics, the biological risk factors include maternal smoking or heavy alcohol consumption during pregnancy, premature birth, low birth weight, and even early exposure to heavy metals like lead or mercury.
It is a biological condition, period.
But that reality creates a massive challenge for doctors. I mean, if the symptoms look like anxiety in women, reckless driving in adult men, and hyperactive disruption in young boys,
Yeah.
how do you actually pin it down?
It's difficult.
I have to admit, I'd be terrified of misdiagnosing this. If the symptoms mimic so many other psychological struggles, how does a doctor know they're actually looking at a broken dopamine filter?
There's no blood test for this, right?
There are absolutely no lab tests for ADHD. No blood draws, no brain scans can give you a definitive yes or no.
That's wild.
Yeah, the diagnosis is strictly clinical, based on the DSM-5 criteria.
Mm.
For children under 12, they need to exhibit 6 specific symptoms persisting for over 6 months.
Okay.
But here is the crucial safeguard. These symptoms must be present across 2 entirely different environments. Usually that means at home and at school.
Oh, that makes sense. Because if a child is only acting out at school, but they are perfectly focused at home, the problem might be a specific teacher or a bully or even a learning disability
Exactly.
rather than a global neurological issue like ADHD. Correct. Context is everything. For adults, the threshold shifts slightly to 5 symptoms, but it requires a retrospective diagnosis.
Meaning you have to look back.
Yeah, the clinician has to prove that these symptoms actually existed back in childhood, even if they were masked or ignored at the time.
Got it.
But to address your point about misdiagnosis, the treatment algorithms reveal a really staggering statistic. Between 50% and 90% of all ADHD cases have an underlying comorbidity.
Wait, up to 90%.
Up to 90%.
Meaning that having ADHD isolated all by itself is actually the exception.
It's very rare to see it alone.
So the vast majority of people are dealing with co-occurring anxiety, bipolar disorder, psychosis, severe depression, conduct disorders, or even Tourette's syndrome.
Yes, which dictates the cardinal rule from the medical texts. Treatment principle number 1, you must treat the comorbidity before you treat the ADHD.
Why, though? I mean, if the ADHD is the root cause making someone depressed because they keep failing at their job, wouldn't you fix the ADHD first to cure the depression?
No. It seems logical, but pharmacologically, it can be really dangerous.
Also,
Think about the nature of ADHD medications. They are often powerful stimulants. If a patient comes in with severe, untreated bipolar disorder or major depression, throwing a central nervous system stimulant into the mix can trigger a severe manic episode.
oh wow.
Or it can escalate their anxiety to the point of severe panic attacks. You have to build a stable psychological foundation first.
Okay, that makes sense.
So the doctor will prescribe bupropion, or an SSRI, to stabilize the depression. Once the patient is out of the danger zone, then you introduce the ADHD treatment.
Or consider a patient with ADHD and Tourette's syndrome. The sources noted that a traditional stimulant can actually exacerbate physical tics.
Yes, significantly.
So the protocol demands starting with a non-stimulant medication to ensure you aren't making their daily life physically harder just to improve their focus.
It is a very careful, systematic untangling of the patient's neurology.
All right, so let's say the comorbidity is stabilized. We finally have a clear runway to treat the ADHD itself and fix that dopamine and noradrenaline radio. How do we do it?
Well, we open the treatment toolbox.
And before we do, I want to bring up something that absolutely floored me in our research. These medications do not improve school grades.
I know that sounds completely counterintuitive to everything we hear in popular culture.
Right. Why take a focus pill if it doesn't improve your academic performance?
The answer lies in what the clinical texts call the compensatory burden.
Let's unpack that because it completely changes how we should view this disorder. The compensatory burden refers to the massive amount of extra energy, the exhausting mental workarounds, and the behavioral detours a person with ADHD has to use every single day just to function at a baseline level.
Yes. Think about the sheer willpower required to force a brain with zero dopamine reward to complete a mundane tax form.
It's like running a marathon in mud.
Exactly. So the medical question the doctor is asking during a follow-up isn't, did you get an A on your math test? The question is, are there fewer negative consequences in your life since you started this medication? Are you less exhausted at the end of the day?
It is about reducing the friction of daily life, extending the attention span, and decreasing the exhausting motor activity.
And the tools used to reduce that burden depend heavily on severity. For mild to moderate ADHD, the algorithm doesn't even start with medication.
Oh, really?
Yeah, it starts with psychosocial interventions, things like social skills training, using heavy-weighted blankets to help with physical regulation, getting extra time on exams to remove the panic of a ticking clock.
Or a really practical strategy I saw, shifting the bulk of homework and studying to weekend mornings when the child's mental reserves are at their absolute highest.
Very effective. But when you move to severe ADHD, the protocol brings in the psychostimulants. And this is where the pharmacology gets incredibly specific.
Okay, let's get into the meds.
The 2 main classes are methylphenidate, which includes brands like Ritalin and Concerta, and amphetamines like Adderall and Vivance.
And the source material practically flashes neon warning signs about this. There is no equivalence between these 2 classes. You cannot just hot swap a patient from a dose of Ritalin to the same dose of Adderall.
Absolutely not. And to understand why, we have to look at their differing mechanisms of action, how they actually interact with the brain cells.
Right.
Both classes work by blocking the reuptake pumps for dopamine and noradrenaline. Essentially, they plug the drain, keeping more of those focus chemicals floating in the brain's synapses.
But amphetamines go a significant step further, right?
Yeah, I do.
Because from what I read, amphetamines actually act as a competitor. They bypass the drain, enter the cell's storage vesicles through a specialized transporter called VMD2.
Yes, the VMA2 transporter.
And once inside, they actively force the stored dopamine out. So it's not just blocking the drain, it's actively squeezing the dopamine sponge.
That is a very visceral way to put it, but mechanically accurate. Amphetamines don't just stop the brain from recycling dopamine, they actively push more of it out into the system, which is why they are considered vastly more powerful and require entirely different dosing scales. By flooding the system and synchronizing those dopamine and noradrenaline signals, the brain's information processing suddenly becomes efficient.
But stimulants aren't the only option. We mentioned non-stimulants earlier for patients with Tourette's. Drugs like atomoxetine, known as Strattera, and guanfacine, known as Intuniv.
Right, the non-stimulants.
Our notes say guanfacine operates as an alpha-2 agonist. What does agonist mean in this context?
So an agonist is a chemical that binds to a receptor and actively triggers a response, mimicking the body's natural neurotransmitters.
Okay.
Guanfacine doesn't primarily target dopamine pumps. Instead, it mimics noradrenaline. It binds directly to the alpha-2 receptors in the prefrontal cortex.
And what does that do?
It strengthens the electrical connectivity in that area of the brain, which improves impulse control and working memory.
But the major trade-off with these non-stimulants is time, isn't it?
Yes, it is.
Because a stimulant works in about an hour. But atomoxetine and guanfacine take 2 to 4 weeks to reach their full effect. Why? If you take the pill on Tuesday, why doesn't it help you focus until next month?
Because unlike a stimulant, which immediately floods the synapse with chemicals, an agonist requires the brain's actual physical architecture to adapt.
Wait, really?
Yeah, you are waiting for the brain to upregulate its receptors and build stronger neural pathways over time. It is a remodeling process, not a quick flood.
That is fascinating.
The immense benefit, however, is that these non-stimulants have zero potential for abuse, and they provide a smooth 24-hour coverage without the sharp crashes of stimulants.
Which brings up the collateral damage of tinkering with brain chemistry. Managing the side effects is a huge part of your daily life if you are taking these medications.
It's a constant balancing act.
And the texts give some surprisingly simple biological advice. Take dry mouth, for instance. That's a huge issue with stimulants. Why does a focus pill make your mouth dry?
Because noradrenaline is heavily involved in your body's fight-or-flight sympathetic nervous system. When you boost noradrenaline to improve focus, the body slightly elevates that fight-or-flight response, which naturally shuts down non-essential functions like saliva production.
And less saliva literally equals a higher risk of dental cavities because you don't have the saliva washing away bacteria.
Exactly.
So the clinical advice is just drink water, chew sugarless gum constantly, and brush your teeth meticulously.
Very practical.
What about the appetite loss? That's another massive one.
Same biological principle. Fight or flight suppresses the digestive system. So the clinical protocol suggests working around the medication's half-life.
Meaning when the drug is wearing off.
Yes. Eat your largest meals when the drug's effect is at its absolute lowest point, the troughs. Have a massive breakfast before the morning dose kicks in, and a large dinner late at night after it wears off.
And for sleep issues, it's about adjusting the timing. Lowering the short-acting afternoon dose or using 3 to 12 milligrams of melatonin.
Right.
But there is one side effect warning in the pediatric section that is treated as an absolute non-negotiable hard line, the 2 percentile rule.
Yes, this is a vital safeguard for children. Doctors are required to track a pediatric patient's height and weight on standard growth charts.
Because stimulants can sometimes suppress physical growth.
Exactly. While a minor, temporary delay is common and usually stabilizes, if a child drops down 2 full percentile curves on their growth chart,
meaning their physical development is significantly lagging compared to their peers.
Right. If that happens, the protocol dictates that the doctor must immediately switch them off stimulants and move to a non-stimulant like atomoxetine.
You simply cannot compromise a child's fundamental physical development just for better focus in math class.
Never.
This actually ties into a question a lot of patients have. Can you just take a break, like a drug holiday?
Yes, you can. The sources suggest occasional summer or weekend breaks, specifically to allow a child's body to recover its appetite and catch up on weight gain.
That makes sense.
It also gives the physician a baseline to assess if the medication is still strictly necessary at that dose.
But there is friction here depending on the drug. The medical texts warn against ever stopping guanfacine abruptly.
That's very dangerous.
Because it modifies those alpha-2 receptors, stopping cold turkey can cause severe rebound hypertension, a highly dangerous spike in blood pressure.
Yeah, you have to taper off.
And for the stimulants, if you do take the weekends off, the source casually mentions watching out for the Monday symptom spikes. I can only imagine the whiplash for a teacher when a kid comes in on Monday morning with their radio dial completely uncalibrated again.
It requires meticulous management from everyone involved. And that management changes for special populations.
Like pregnancy.
Yes. For instance, during pregnancy, ADHD is typically only treated pharmacologically if the symptoms are severe enough to threaten the mother's livelihood, and the preferred agent is bupropion rather than traditional stimulants.
And then there's the incredibly practical issue of getting a 7-year-old to actually swallow these pills.
Always a struggle.
If a kid can't swallow a capsule, the pharmaceutical companies have built workarounds. You can open and sprinkle capsules of Bifenton or Adderall onto applesauce. You can dissolve Vivance in water.
Very helpful for parents.
But the sources are flashing massive warning signs about Concerta. You must never, ever crush, chew, or cut Concerta. Why is that one so dangerous?
Because of how it is physically engineered, Concerta uses a highly specialized Oralase matrix formulation.
Orus matrix.
Yeah. Inside that pill is a tiny, literal sponge and a laser-drilled hole.
A sponge?
A physical sponge. As the pill passes through the digestive tract, the sponge absorbs moisture, expands, and slowly acts like a piston, pushing the methylphenidate out of the laser hole at a steady rate over 12 hours.
That is wild.
So if you chew it or crush it, you destroy that release mechanism. And you deliver 12 hours worth of powerful stimulants into the bloodstream in 10 minutes.
A massive overdose, essentially.
Exactly. It's a marvel of pharmaceutical engineering, but it requires strict adherence to the instructions.
Wow. So let's zoom out and look at the ground we've covered today. We've gone from understanding the neurobiological radio noise caused by dopamine and noradrenaline deficits to seeing how this disorder hides in plain sight.
Internalized as mental restlessness in adults and emotional dysregulation in women.
Yeah, we've navigated the vital logic of treating comorbidities first, and we've unpacked the heavy pharmacology of VMAT2 transporters, alpha-2 agonists, and laser-drilled pills.
The takeaway here is a profound shift in perspective, moving from viewing ADHD as a behavioral nuisance to respecting it as a complex, highly varied neurological condition that requires precise, individualized medical care.
And I want to leave you, the listener, with one final thought to mull over. It goes back to that heartbreaking observation we discussed earlier. For an individual with ADHD, success and achievement are the only antidotes to low self-esteem.
A really powerful thought.
We learned today that the ultimate medical goal of ADHD treatment isn't to make someone smarter. It's to reduce the compensatory burden, the sheer soul-crushing exhaustion of trying to function normally in a world that isn't built for your brain.
Right.
So we have to ask ourselves, if an ADHD brain is just a radio tuned to a different frequency, how much the disability they experience is actually caused by the biology of the brain itself? And how much of that exhausting compensatory burden is caused by a society that stubbornly refuses to adjust its own dial to meet them halfway?
That is the essential question as we rethink what it actually means to be neurodivergent in the modern world.
Until next time, keep digging deeper.